Good morning and welcome to the 33rd meeting of the Health, Social Care and Sport Committee in 2025. I've received no apologies for today's meeting. The first item on our agenda is for the committee to agree to take items 3 and 4 in private. Do members agree to take these items in private? Thank you. Second item on our agenda is to take oral evidence from 2 panels of witnesses as part of the committee's Stage 1 scrutiny of the Non-Surgical Procedures and Functions of Medical Reviewers Scotland Bill. Our scrutiny of the bill this morning is specifically focused on Part 1 of the bill. The first of this morning's panels comprises representatives of consumers and individual practitioners involved in the provision of non-surgical procedures covered by the bill. And I welcome to the committee Louise Caithness, Founder and Managing Director of the Zest Group Scotland, Tina McCafferty, representing Skin Religion Aesthetics, Douglas White, Director of Policy and Advocacy, Consumer Scotland, and Lindsay Wilson, Co-Chair of Scottish Aesthetics Safety Standards Group. We'll move straight to questions and Emma Harper.
Thank you. Thanks, Convener. Good morning to you all. Thanks for being here today. Basically, I'm just going to kick off and ask you what your views are on the proposed bill that we have in front of us, but specifically the regulation of non-surgical procedures that has been set out in the bill.
Am I going first? It's a huge bill, so to give one opinion it would probably take quite a long time today. I think my sort of overriding thought is that this has become quite a divisive subject, and that is a challenge for those out there working in industry. We've become a very medic, non-medic argument, and that is detracting from what the overriding goal is of this bill, is to ensure public safety. I think for me that the bill must, and the committee must approach a very fair framework so that we look really hard at robust training. So regardless of whether somebody has already done a general nursing, general medical or general dental degree, that is not a necessary prerequisite for the delivery of some of these treatments that are less invasive. And we must look at what the regulatory framework of training produces, and that those that are looking to work in this industry must follow that particular framework. And as I say, it's regardless of what their background can be. We've got practitioners working in the industry at the moment who are working very, very safely, who do not come from medical backgrounds. And I don't think they should be unfairly disadvantaged because of a new bill. The bill should look at how we can bring everybody up to a similar standard to work safely and ensure public safety.
Okay, thanks.
So we at Consumer Scotland welcome the introduction of regulation to bring greater protection, consistency, clarity and certainty for consumers. Given the growth that there's been in the non-surgical procedures market and the range of evidence that exists from a range of different sources about the potential for consumer harm to occur. At the same time, however, we don't underestimate the challenge that regulation presents to many small businesses across Scotland in meeting the new regulations and the risks that presents in terms of potential negative consumer outcomes, such as the potential risk of higher prices or of loss of services. So we will obviously get into lots of the detail during the discussion, but as a kind of high level for in terms of your opening question, I think 3 kind of key steps from our perspective to make regulation work in practice. Firstly, the public need to know about regulation and understand what it is trying to achieve for them, and provide them crucially with the information that they require in order to make informed choices about the treatments that they choose to receive. Secondly, small businesses need the right support to help them make the journey to regulation, and it's very important that government works with industry to achieve this and looks at how those good businesses who want to comply and to adhere to the standards that are being set are able to do so. And that's important for businesses, and it's also important for consumers. It's good for consumers if good businesses are brought along that regulatory journey. And then thirdly, if regulation is to be meaningful, then it's important that it's essential that appropriate resources are provided for enforcement. Otherwise, there's a risk that the system will be undermined, which can create a higher level of risk for consumers if there are significant number of businesses operating out with the new regulatory system, and therefore it's essential that there are sufficient resources to enable the new system to be enforced.
Okay. Lindsay, I'll give you an opportunity as well.
Thank you. So first of all, safety should be the main concern, and we do support a regulation that is proportionate and going to provide safety for all people seeking out cosmetic procedures, or non-surgical cosmetic procedures. From the majority of complications that arise, it is clear that that comes from unqualified and untrained professionals or injectors, and not from qualified aesthetics practitioners. For a number of years, there has been an influx in training academies, offering substandard 1- and 2-day training, which has seen a rise in complications across the industry. So we believe that it is important to introduce training and qualifications to ensure that practitioners offering these treatments are competent, they're qualified, knowledgeable, and able to offer safe treatments. The regulation itself poses quite a disproportion to non-healthcare providers. The regulation for HIS clinics would mean that non-healthcare practitioners cannot register their own business without a healthcare professional. Scottish Government at the minute don't have any data to suggest how many qualified prescribers there are in aesthetics that could facilitate the number of clinics that would need that oversight. So we believe that it's important to create a regulation that is fit for the practicalities of the industry and not just good on theory. We need to understand the diverse practitioners that are within the industry, that's been in the industry for numerous years providing safe treatments. So we do look forward to being able to find a regulation that fits a model fit for purpose.
And so if we're, safety is like number one concern, I need to remind everybody I am a registered nurse. Surgery was my specialty in clinical education. So I'm interested in about how do we, well, what do we need to do to make sure appropriate steps are taken to support people to obtain appropriate qualifications and safety, but then there's also the consumers that are seeking procedures that are at different level of invasive non-surgical procedures. How do we support consumers to be better informed as well?
So I would essentially say that there is a Level 7 government-approved qualification in aesthetics practice. Now, that obviously training hasn't been implemented into the bill, but many practitioners hold this qualification, and that ensures that they have the competency and the knowledge and skills to deliver these treatments safely. It is important that anyone seeking these treatments has an understanding that every practitioner they go to has that level of qualification. Perhaps there could be a tiered approach in regulation in terms of what treatments are done and by who. There are more invasive non-surgical cosmetic procedures that I don't believe are appropriate for certain practitioners without a medical background. So for me, I think making sure that qualifications and training is implemented into this bill, that would give consumers the confidence that the practitioner of their choice has a qualification and been able to deliver those treatments safely.
So thank you. So if I separate your question out into into two parts, which are clearly related, but if I can separate them out to kind of address them in that way, the first kind of part around training, so and qualifications. So at the moment we obviously have a system where we have quite a range of different levels of kind of qualifications in the sector, in the market. We have regulated healthcare professionals delivering procedures. We have practitioners who have undertaken, as Lindsay's describing, a lot of training and gone through specific qualifications to deliver procedures. And then we have other practitioners who have very limited or even no training delivering procedures. And from a consumer perspective, that's clearly far from ideal, because it's often not straightforward or easy for consumers to know what type of qualifications different people offering procedures might have, and also to really understand what that means for them in practice in terms of that being a safe procedure for them to undergo. So the bill obviously allows ministers to specify detailed requirements in relation to training and qualifications in secondary legislation, and we would very much support that being taken forward. I think given the range of different ways in which that could be done, I think taking that forward in secondary legislation makes sense to me, because it allows there to be proper kind of consideration of the different options and models that could deliver that effectively for consumers. On your question about public awareness, which I think I agree is extremely important. I think is one of the fundamentals to making the bill work effectively. There needs to be public awareness raising materials and campaigns to let the public know about the new regulatory system and the standards that it's setting and what that means for different types of procedures and who is able to provide them. We also think that there's an opportunity to go a little bit further on the face of the bill and give ministers the opportunity to specify information that providers must give to consumers when they come to receive a procedure. And many practitioners will already do this, but by making it part of the regulatory system, we can make that consistent kind of across the board. So if providers were required to give consumers information about the levels of risks involved in a procedure, the aftercare instructions, success rates, qualifications of staff, how to make a complaint if something goes wrong, and any other kind of information that's kind of vital for helping consumers make an informed choice about the procedure they want to undergo, then that would be a really important step in terms of making sure that consumers and the public are well informed. And then the third point I would just make very briefly is work around advertising and working with the Advertising Standards Authority to make sure that the adverts our advertising procedures are accurate and are not misleading and don't make consumers feel pressured into making choices. That's like an important kind of third plank of that public awareness work.
We are going to come on to some of those points. Yeah. Tina McCaffrey was one to come in.
Okay.
Am I on?
Yes.
Thank you, convener, and thank you to the committee for inviting me to give evidence today. I agree with what has been said by Lindsay and others. I represent the various non-medic practitioners across Scotland and across England. And I would like to begin by saying that whilst we all fully support these regulations and that the industry needs to be regulated, it needs to be done fairly and with public safety being paramount. But for regulation to work, it's got to be evidence-based, proportionate, enforceable and accessible across Scotland, including rural and remote regions. At present, we know that Scotland has no centralised adverse event reporting system. There is no national register, no minimum training or qualification standards, and no data on the real scale of complications or illegal practitioners. This means we are trying to regulate without a really accurate picture of the risk, and that is unsafe for the public. I also want to highlight the issue of prescriber access, which is uniquely challenging in Scotland. In some areas of the Highlands, for example, there is
Ms.
one...
McCaffrey, we're going to come on to some of those themes further on, so if you can just continue your remarks to the questions that have already been asked.
Okay, I think I'll leave it at that for now.
Okay, thank you. Sorry, it's much more difficult when you're online to get your attention.
I think, I think I'll let others come in because I'm sure there'll be other information to be picked up regarding data and adverse reaction tracking and things like that.
Sanjay Gohani.
Thank you, and a declaration of interest of practising NHS GP. Thank you very much for coming in. I do have a number of questions. Louise, if I could start with yourself. So, your clinic offers mole reduction.
It does. Yes.
How do you ensure there's no cancer?
Because we perform very thorough consultations We also, as part of our training, look at identifying moles or blemishes that are safe for us to treat within our scope of practice, and those that we know are not safe to treat. Training is very comprehensive, and we have access to additional clinical oversight through programmes like Map My Mole, Spot Check, where we have direct access to dermatologists that we refer our clients to if we are not confident that we can correctly and safely identify a blemish.
So you only have one nurse who is registered to do this?
We don't have any nurses.
Oh, right. On your website, there is somebody who is a member of the dermatological
Correct.
nursing.
So through our association with the British Institute and Association of Electrolysis, who we deliver advanced electrolysis treatments, they are our, not a regulatory body as such, but an association that we work closely with to ensure safe standards and training across all of our treatments. Because we're members of them, we can be associate members of the British Dermatology Association of Nurses as well.
Okay.
So we access their training material.
But there isn't a nurse or a doctor or somebody who has been trained in skincare?
No, it's not necessary for those
you're
treatments.
one of the bigger clinics.
Yes.
So if we look at other places that offer it, what safety mechanisms are in place to ensure that people aren't doing things to a cancerous mole?
Well, we would hope that those that are delivering the treatments are appropriately trained, and certainly in my clinic that they are, and appropriately insured as well. They also have the skills to identify the blemish, and we have the skills to identify a blemish that perhaps has the potential signs of not being stable and therefore not safe to treat. And we would refer those clients to dermatology. We've got a track record of numerous clients that we've done that with, who have then come back to us and said thank you. We've sought medical advice, medical treatment, and had this mole or blemish that you identified as not being safe to treat. We've had it removed under a medical situation, and it has proved either to be benign or in some cases not benign.
Okay. And if we, Douglas, if I can turn to you, you spoke about significant risk for the public if clinics operate outside of the legislation that might come into force. That's illegal. So why should there be a single clinic that operates outside? And if it does, surely they should be sanctioned by the police.
So I think what will be required is the resources to identify where that's happening and find where that's happening. So,
but forgive me, you said significant number of clinics operating outside of the legislation. So that would be easy. It's significant numbers.
So I was posing, I suppose, the hypothesis that if there is not sufficient work to make sure that businesses are brought on the journey to be regulated, which is what we want. We want consumers to be able to access treatments in safe places and understand the kind of consistency and the clarity of the standards that those providing them will offer to them. We would be concerned, as I think we'd be kind of in any kind of industry where new regulation is coming in, that some people will choose to continue operating outside of that, and that could pose risks for consumers. I think we are in favour of the regulation. We're thinking through what might be the risks that could occur that we need to mitigate in terms of taking it through. And one of the things that we're saying is that good, sufficient enforcement powers and resources are important to make sure that we pick up on where those people are outside of the regulation, and that therefore appropriate action can be taken against them to protect consumers from harm that they're offering. What routes through that enforcement is undertaken, that would be whatever is appropriate. But it's important that attention is paid to that to make sure that doesn't occur, and therefore consumers are appropriately protected.
Okay. And Lindsay, I think maybe Douglas, you might want to come in on this. What mechanisms exist to hold aesthetic practitioners to account for things that go wrong at the moment?
At the moment, currently, insurance. So obviously, any regulated professional who would be under the NMC, GMC, they have a regulatory body. So non-healthcare practitioners don't have that, to no fault of our own. We are looking to find ways where we can see where there's accountability in the industry. Right now, it's just relying on insurance. However...
So is there any mechanism at all that exists right now?
Right now, I don't believe so. If a client had any complications, I would be hoping that they would return back to their injector. If that complication needed oversight from a medical professional, we do work collaboratively with prescribers who we would then refer to them. There are HIS clinics across Scotland to offer complication support. They have ultrasound, they have other mechanisms in place that we can ensure any clients with complications are treated with medical professionals. Right now, there is no body for non-healthcare practitioners, and I do believe that's something that should be brought into place. There should perhaps be a governing body and also a mandatory complications database. We see across the board that there are complications being recorded. Healthcare practitioners are saying they're treating complications. So we sent a Freedom of Information request to Healthcare Improvement Scotland. The information from that report would indicate the Healthcare Improvement Scotland set up a new for complications for dermal fillers. So there was 3 reports in 2023, 2 in 24, and that evidence is suggesting that complications that are being treated are not being recorded. So we need to have a mandatory system in place. We need to create accountability for all practitioners, and that would be something that I believe is down to Scottish Government to try and create. Even if we were all under Healthcare Improvement Scotland, Healthcare Improvement Scotland don't conduct any audits, they don't do any follow-ups on complications. It's more or less that the paperwork has been filled out and it's been recorded, and that's the end. There's never a process to find out whether that client has successfully been treated. So I do believe that we have to create some kind of governing body to ensure that there is accountability across the board for all practitioners offering aesthetics.
I mean, this does feel a bit like the Wild West when it comes to the industry compared to healthcare, where complications are very much looked at, and there's an entire mechanism process. And Louise, can I turn to you? In your submissions, you spoke about how it's nonsensical to include things like skin peels. So what's the complication rate on skin peels?
Complication rate on skin peels is incredibly low.
What is it?
I don't know exact figures. I know for my own business, we have 0 issues with skin peels because they are such superficial treatments. I think it's nonsensical to regulate products and treatments that consumers can purchase and deliver themselves at home. And I think that's where, in the consultation, it was very grey and woolly as to what these treatments would look like. So, for example, things like skin needling. We've just had a Black Friday weekend where these products and treatments were awash for people to purchase without any training or any guidance of use for them to use at home. You refer to the Wild West, and I would agree there is that in any industry, but what seems to have happened in this sort of conversation
you
around
think
regulation...
there's Wild West in medicine?
No, I'm just saying you mentioned the Wild West, if I could continue. You mentioned the Wild West, and I agree that exists in any industry, and certainly there's elements of that in the non-medical aesthetics arena, no doubt about it. But what seems to have happened here is we've got those that are delivering the Wild West treatments, quite how that looks, I'm not totally sure. We've then got those that don't come from a medical background but are suitably trained, qualified, and are delivering treatments safely. And then we've got those that come from a medical background that are delivering treatments. So I think to put those that are non-medical background into one category with those that are defined as Wild West is very, very unfair and nonsensical. And we need to look at the delivery of these treatments, and in fact they are ultra low risk. A skin peel can be something that, by name is called a skin peel, but by design does not peel the skin at all. And the same can be said for skin needling. These are very, very superficial, non-invasive treatments that pose an ultra-low risk. Okay. They are elective, non-medical.
I mean, the complication rate is 3.8%.
Okay.
And it
to what particular
upon,
peels do you refer to?
Well,
with that?
Well, that's superficial, and it goes
Right.
up with it goes up with medium and deep peels, and the complications seem to end up with general practitioners who have no idea about the chemicals that have been used, and that is one of the concerns that I certainly was asking Lindsay about. But I shall leave it there, convener, because other people want to come in.
Thank you. Brian Whittle.
Thank you, Kavita. Good morning to the panel. I'm actually going to extend that a little bit. I mean, I completely accept, Ms Caithness, that there are those in the industry out there who deliver a proper, thorough service as opposed to those that we're looking at the moment. I think my concern here is that healthcare is a science is inexact. You never know when a complication may arise and why that complication may arise, and which is why I'm asking the question: why would you not have? Surely it's important to have a medically trained person on the premises, specifically for a sort of complication that is it's not foreseen. Why would you not have a medical professional on site for that?
I think because if the individual delivering the treatments has got complication management training, which is built into the regulatory framework of training, then there wouldn't be a requirement. We spoke about a 3% report of skin peels. That means there's a 97% people who are not experiencing, complications. It is, in certain procedures, absolutely not necessary to have a medical individual present on site because they are not medical treatments. In the same way that you wouldn't have a medical personnel on site on a building site where someone could fall from the top tier.
Well,
it's there's risk in every industry.
I'm not going to accept that analogy.
Okay, well, there's risk in every industry, but when we're talking about ultra low risk, non-invasive treatments,
4 out of 100. 4 out of 100 in one of the most basic procedures. I'm not here to
absolutely. We're not necessarily agree on it.
My
But
point is that healthcare is an inexact science.
Absolutely.
And if the most basic procedure that you do has 4 out of 100 people have complications, surely to goodness, then you need somebody on site and you don't know what those complications are going to be. If you're not a medically trained person, you wouldn't understand what all those complications could possibly be. And all I'm asking here is that, or exploring the thought that potentially there should be somebody that's medically trained on site.
Can I ask, the 4 out of 100, were those from treatments that were delivered by untrained or non-medical trained? We don't know.
No, I don't.
And this is the issue, what I've just said, that we're categorising those that are non-medically trained into a bucket of people that are not trained, full stop, and that's not fair.
Totally accept. I'm coming at this from a layman's perspective.
So,
I understand this, but for me, listening to somebody saying needle procedures are non-invasive doesn't wash with me. I'm sorry. I'm thinking, and again, I'm not here to.
No. And I think this is what's so important.
I totally appreciate that there are many out there that are delivering a very good service.
Yeah.
My issue is what happens if there's complications. That's what happens in those situations.
Then those that are delivering those treatments are trained to manage complications. It's built into the regulatory framework that is the SQA, Ofqual, HABIA for the Health and Beauty Industry Authority. They're building complication management. It already exists. The framework is already in place for anybody delivering these treatments. What they should do should a complication arise.
I don't know if anybody else wants to come in on that point. Lindsay, have you got something to...
Yeah, so again, just touching on qualifications and training, within the Level 7 qualification, that can take a number of years to complete. You are doing advanced facial anatomy, management and complications training, first aid and anaphylaxis, injection techniques, pharmacology of products. There is obviously a range of different providers, but each of these are Ofqual regulated, so they're individually assessed. There's a lot of complications that can happen, and most complications are mild, which would result in bruising, swelling and some injection redness. You do experience more severe complications, but again, these would generally come from unqualified practitioners. From the data that I've been able to gather, there is an estimated 1% or less chance of vascular occlusion through dermal filler. And sometimes that's not always presented there and then at treatment. That can develop a few hours later or into the next day. So having a medical professional on site during the delivery of that treatment might not always be needed. It could be that we have to access that practitioner or the prescriber when that complication arises. There's also a 0.63% chance of developing anaphylaxis through hyaluronidase. So again, we as non-medical professionals are not claiming that we have the same knowledge of healthcare experience, but we do have a level 3 first aid and anaphylaxis training. We do have the ability to recognise anaphylaxis and the ability to know when an EpiPen would be needed. Obviously, this is a prescription-only medicine, but if we're looking at public safety, we need to develop ways to keep qualified practitioners collaborating with medical professionals and ensure that we can deliver safe, timely treatments in these rare cases of adverse events. Now, when we talk about the complications that arise, from the data that's available, it does show that these are from what we're calling rogue injectors and not from qualified practitioners. And as Louise had said, we need to stop putting those people into the same category. And it's the same in most industries, including healthcare. You'll have stories that pop up when there's complications through healthcare, malpractice, things like that. And again, we don't put all healthcare providers into that same bracket, and it has to be seen the same from qualified aesthetics injectors as well.
Thank you.
Joe Fitzpatrick.
Thanks very much. Obviously, this is a UK-wide issue. It's been dealt with in Scotland and England though in different ways. So the regulations being proposed in this bill are not the same as the approach that's been taken in England. So, Lindsay, what's your thoughts on the two approaches? Have we got it right here, or is there something more we can learn from what's happening in England?
So, regulation is absolutely something that we do support, but we do support a proportionate regulation. Since the Key-Off report in 2013, there was awareness raised to the Scottish Government on the potential risks associated if regulation wasn't brought in. But for over a decade, the Scottish Government have allowed practitioners to undergo qualifications, create businesses, develop careers and livelihoods. And now this regulation poses a major impact on those professionals. So in Scotland, they are proposing their licensing model, which would allow healthcare and non-healthcare practitioners to work from the same premises without any major restrictions. And in Scotland, we have HIS. So that means a non-healthcare professional can't register their business without a prescriber. So the consensus across most of the practitioners across Scotland is the concern for finding that prescriber that is available in aesthetics to cover these clinics that need that medical professional. So, and as I said before, the Scottish Government don't have any data on how many prescribers there are qualified in aesthetics to oversee that. Does that risk prescribers leaving NHS services to move into private clinics? And again, if we can't have enough prescribers to facilitate these clinics are going to be forced to close. That then pushes consumers into not having the same safe access to treatments that they had previously. And that is a concern to where will they then go. So I do believe that a different model could be approached. I also think perhaps an amendment to the National Health Service 1978 Act to allow the recognition of non-healthcare providers qualified in aesthetics to a minimum of level 7, to come under that scope of professional who can register, have collaborations with prescribers that are available within a short radius, so that in the rare event that they are needed, they can be contacted and they're within a time frame. Obviously, sorry.
I'm going to have to get you to,
sorry, okay.
to wind up. We have 50 minutes left of this session. We've still got an awful lot of questions to get through. So if we can keep questions short and answers concise, that would be very helpful. In terms
so I think that's been
management.
helpful, because I think you've laid out the difference in, whether it's safer, the model in England or here, will be something we can discuss later. I wonder, moving to Tina then, just obviously, Tina, you said that when you spoke before that you represented practitioners across Scotland and the UK. Do you want to explain that before I ask the question, just who it is you represent? And actually then, if you could go on to maybe talk about the impact of having different regulations in Scotland and the rest of the UK.
Yes, of course. So I set up a group called the NMAC, and we're there to basically represent the non-medic practitioners across Scotland and across England, so that we can get their views overall on the different systems that are in Scotland and within England.
So that's useful then, that you're maybe able to talk about from the point of view of practitioners in England and practitioners in Scotland. So there's obviously two different regimes being proposed, and it'd be good just to hear your thoughts from an industry perspective. Direct.
Okay, so we all are desperately wanting regulations across the devolved nations. However, the two formats that are running, the one in Scotland and the one in England, are incredibly different. As we know, England are looking at going down the licensing route with local authorities, whereas here we're going to be bringing in HIS, HIS and prescribers on premises. Our members are all saying that they would prefer the licensing route, so that it is governed very similar to the licensing that's already available for various things like microblading, tattooing, etc., compared to what is going on in Scotland. You've also got a lot of concern how the Scottish regulations are going to, and the licensing within England, are going to work together, because they are so very different in their model style. In Scotland, having HIS is with the prescribers, as Lindsay was saying. However, you can't look at the practitioners, non-healthcare professionals, being put into HIS registered premises and having, this brings you back to one of the other concerns of prescribers on premises at all times. That's a heavy burden that, one, isn't financially practical across the board, nor is it practical for non-healthcare providers who are trying to run their businesses correctly. I can't hear you.
Sorry, thanks, Tina. Convener's minded me that I need to move on. So unless Louise has something very specific she wants to add from that kind of industry perspective.
Just more about the HIS registration for Scotland and the practical element of that.
Okay.
we're a very diverse industry, predominantly female-led, and many of our specialists in industry work in very flexible locations. They might rent rooms on a relatively ad hoc basis, a lot work from home because they balance the burden of childcare as well. This regulation will inhibit them from being able to continue practising in those locations because practically they won't be able to make the adjustments to meet the standard, and financially they won't be able to do it either.
Helpful. I guess that might be some of the concern that some of us have, is that kind of ad hoc work is of huge concern, I think. Douglas, very quickly, from your perspective, is there any concerns about having different regimes in Scotland and England?
Yeah, thank you. So, I'll try and be... I think it's about a hierarchy of what your concerns are from a consumer's perspective. As we said at the outset, top of that hierarchy is improving safety. So we have to regulate in the appropriate way that we think we need to in Scotland to improve safety. That would come first. There's then a question about proportionality and making sure we have the right level of regulation for different procedures that maximises safety, but equally, or not equally, maximises safety, but then also tries to ensure consumer access as well, where it can be done safely. Where we can get as close as possible to the UK in doing that, that is clearly good for consumers, and it's better not to have differences in regime. But it depends if that can be squared with those other priorities. I would note as well, just very briefly, that the model in England, the licensing scheme does talk about supervision by regulated healthcare professionals, but there isn't a lot of detail available yet about what that means in practice. And equally, in the bill we have in Scotland, we have language on the bill about when regulated healthcare practitioners are on site and procedures are being undertaken under their management or in accordance with their direction. I think some more clarity about what that means in practice would be helpful for consumers to know exactly what that means. And while that kind of parallel debate is going on in England about what supervision means there, those two things feel like it would be helpful for consumers if they played out to achieve as consistent approach as possible. But safety is the top goal.
Okay. Thanks very much, Douglas.
Fine, Whittle.
Thank you. I'm going to look really about, what's driving demand for non-surgical procedures and how things like advertising, how body image pressures influence that. I would ask, is that more acute for the younger generation under 18, and potentially limiting these procedures to 18 plus, how that might mitigate that. And I think, again, one of the things, some of the advertising around this is how do you manage unrealistic expectations from cosmetic procedures? Yeah, Louise.
Me? Waiting for somebody else to speak. I think that there should be an age restriction. I totally agree with that. I don't think it is good practice to deliver these treatments to those that are under 18 years old. Certainly we don't do that in my business. We have had requests in the past from parents. We do like wart removal treatment, verrucate removal treatment. We have had requests from parents for that for under 18-year-old, but we don't deliver those treatments. It's not part of our business model. I think for those treatments that are purely looking at aesthetics and appearance, again, I don't think that it is good practice to deliver it to under 18, so I do agree that that should definitely be in the bill. In terms of how we advertise these treatments and what consumers are looking for, I think it's very cost-driven in certain areas, and others it's not. We've got a very wide range of consumers. I know in my business most of our clientele is around about my age, which I'm not going to disclose, but we don't have a younger or audience, and I think that most people will be driven to or be attracted to a sort of like-for-like business model. So whether it's somebody that's working on the high street, or certainly somebody that's working from home versus those that are working in a more clinical environment, we will attract a very, very diverse audience. As diverse as the industry is, the same diversity would apply to our consumers as well. So I think in terms of advertising, I agree with Douglas that the regulation has to be advertised in such a way so that consumers know what to look for.
Okay. if I just layer on top of that, because we're a bit short of time, it's that unrealistic expectation in certain unscrupulous advertising, shall we say? How do we prevent that? I mean, it is a mental health issue, actually.
Yeah. So, the Advertising Standards Authority has issued an updated guidance in this area, which requires adverts to be responsible, that they hold evidence for claims of their efficacy, and that they don't exploit insecurities or portray offensive stereotypes, and shouldn't trivialise the procedure, which I think is a really helpful framing. And I know that in its submission of evidence, the Advertising Standards Authority said that it would be keen to explore with the Scottish Government the practicalities of enforcing advertising restrictions, particularly if the advertiser isn't a registered provider, clarification on who they should engage with and possibly refer non-compliant advertisers to, and the guidance it provides to advertisers. And I would very much kind of agree with those points, that the engagement with the ASA to make sure that its guidance is being applied by all practitioners will be important. I think, secondly, I would just say briefly, I think it's really important that practitioners are aware of and have an understanding of these issues, and are able to ideally signpost people to proper trusted mental health support organisations for these issues, and that can be something that could be looked at, I think, in terms of the kind of that provision of information to consumers and what would be appropriate information for practitioners to be required to practitioners. I think some consideration should be given to whether signposting to appropriate mental health support would be could be taken forward as part of that.
Could I just add, sorry, just with response to what Douglas has said, that is built into the regulatory framework for training already, that we ensure clients can give proper informed consent before their treatment's carried out. And part of that process of informed consent is making them aware of the risks, complications, benefits of treatment, and also alternative treatments, and also for the practitioner to recognise whether it's safe to proceed with the treatment, not least on a physical but also mental and emotional basis as well.
I'll just quickly say that we absolutely support that these treatments should not be carried out on anyone under 18. In terms of advertising, social media, there's content creators, there's advertisements of prescription-only medicines happening all the time from both healthcare providers and non-healthcare providers. And although the ASA have set out their rules, that's not always followed. So, unfortunately, from my position, I'm unsure what can be done in terms of the ASA putting something in place to ensure that these social media contents are not put out to encourage young viewers. In terms of, unrealistic results, during your qualifications and training, anyone who's going through this rigorous qualification, ethics is part of that, and any ethical practitioner would not do a treatment that is just for. Every treatment must be suitable for the client. And again, I would probably say that the vast majority of people that have had extreme non-surgical procedures done, it's probably being carried out from someone who is not entirely qualified, or they're just not ethical in their practice and what is suitable for that client.
Thank you,
And Tina, you wanted to come in on this?
Yes, just quickly, I'd like to take it from the perspective of the mental health side of it, because we know that there are risks physically, but psychologically the risks are very high. So there's currently no real requirement within this bill to look at body dysmorphia and the various aspects. And as has rightly been pointed out, within the qualifications, especially at level 7, we do train practitioners in all of these flags for body dysmorphia. But you need to look at this being introduced from a training perspective, that practitioners are all required to have proper training in identifying the vulnerable clients that walk through those doors when it comes to body dysmorphia from a psychological point of view, because whilst it is in qualifications, it's not really within this current bill and set out to ensure that happens.
Thank you, Kavira, and thank you to members of the panel. We'd just like to ask a bit more about what impact the proposed bill would have on small, independent or home-based businesses, and how regulation could be designed in a way that improves safety whilst not creating barriers that drive people to use unregulated providers. So perhaps if someone would like to start.
Yeah, I think post-COVID, we saw a huge change in the beauty and skin industry. Many salons closed because it wasn't financially viable for them to continue. And we saw a drive in people working from home more. So city centres have changed, the dynamic has changed of where people are moving throughout the day. We've seen a huge increase in practitioners working from home, cabins in their gardens, that sort of arrangement. And that works extremely well. It allows predominantly women and mothers to carry the burden of childcare and work in a safe environment at home that's accessible for their clients as well. Under the sort of the HIS framework, it would virtually be impossible for these types of practitioners to convert and meet the necessary arrangements just by the practicalities of where they're working from, and also financially too. I think it would be really beneficial for the bill to look at perhaps a tiered approach to HIS, so that those that are delivering non-invasive treatments could continue to do that with some basis of regulation, as opposed to the greater HIS umbrella that covers surgical procedures. There's not a balance there, and I think that's important to recognise that there are a lot of people working in sort of very diverse environments. I mentioned earlier about ad hoc arrangements. What I mean by that is people rent clinical spaces or rooms to work from, not on a full-time basis. It doesn't mean that their delivery is ad hoc or substandard by any means. It just means that they're not committing to business premises on a full-time basis, which is just cost prohibitive. So it's important that the bill looks at that the diversity in our industry that we value and that we should not be inhibiting the growth of.
Thank you. Is there any other views on this?
Yeah, so the implementation for HIS regulated clinics has a massive impact on non-healthcare professionals. We would not be able to register our business without a prescriber, and as previously discussed, the prescriber availability is extremely short at the minute. Small businesses run from a predominantly female-led industry. Even although if we want to comply without that prescriber, we have no means to do so. So there has to be something in place that allows qualified aesthetics practitioners the ability to register their own business in their own right and implement something that is actually workable within the sector across healthcare and non-healthcare providers. Currently at the minute, if you do not have a prescriber available to attend your clinic during your working hours, you can't work. If you do have a prescriber but your prescriber's off sick, you can't work. If they're on holiday, you can't work. And that would be more difficult if that prescriber had to be employed by the person, because, again, if they were off sick, they would still be entitled to money from the company, but the owner can't work. Now, that might sound, it's fine if this is in larger clinics and there's other means to support that, but the vast majority of prescribers, practitioners within the industry are independent, female-led small businesses who are working on their own and with collaborations with prescribers. Through COVID, as Louise said, models of working had changed, and I do believe that there is a safe way to introduce a regulation that is effective and proportionate, providing safety for members of the public, but also protecting the large number of small businesses and the growth in the economy. I don't believe this regulation current is fair just now. It's completely pushing qualified non-healthcare aesthetics practitioners out by requiring a prescriber to even register. So if Scotland were to perhaps adopt a similar model to England, they would still have to make amendments to the 1978 Act to allow prescribers to access these local authority registered clinics. And as I said before, at a minimum, amend the 1978 Act to allow qualified non-healthcare practitioners to fall under a regulatory system, perhaps create a separate category for aesthetics. As Safe Face had put in their response for call for views, they outlined that HIS was set up to obviously regulate kind of hospitals, theatres, surgeries, and that level of clinical standard is not exactly necessary for some aesthetics treatments. So I think there has to be a more tiered approach or a separate category created that is inclusive for all practitioners within the industry.
Thanks. Kind of briefly, just on a slightly kind of different perspective from the kind of consumer side. So obviously, really hear and emphasise with the challenges that colleagues are sharing around that kind of journey to regulation, and desire to find solutions that enable practitioners to operate in safe ways under different kind of types of regulation. I would just say that from a consumer perspective, the more that we have differing levels within a system, whether that's around premises or practitioner qualifications or standards, I think we'd have some concerns about the risks that might present in terms of clarity and consistency and certainty for consumers about where is it they go, for what type of procedure, and what are the kind of standards or qualifications that different people are adhering to. So there may be ways to achieve it, but I would have that kind of principle about consumer certainty and clarity, and safety. Obviously, is pretty kind of key, is pretty kind of core to decision making around that.
So your key issue is the level playing field.
Yeah. So the kind of second point I was going to make around that is I do think it is absolutely essential that we look at what are the steps and the actions that can be put in place to help existing businesses on that journey to regulation, whatever that ends up looking like, and whether that is to do with funding support around premise changes to premises that might be required, whether that's looking at what are the models by which regulated healthcare professionals or prescribers are available to people. I do think it's really important that we take kind of that business development and business support angle to it. While at the same time seeking to achieve that kind of certainty and consistency and clarity for consumers.
Okay, so there's a point about proportionality of the regulations, and then also this idea of the level playing field, and then a pathway to reaching compliance. Do you have a view of what support would be helpful to meet compliance with this? You mentioned prescribing was a practical challenge, but you did work in or practitioners do work in collaboration with prescribers, so maybe that's one example of where this could be more tailored or more nuanced.
The limitations right now are that prescribers cannot work out with HIS clinics. So therefore, currently at present, if a non-healthcare professional who's not in an HIS clinic can't have a prescriber present for a face-to-face consultation or to assist for anything other than that. So we really need to find a way to bring the industry together that is inclusive. It can't just be that you have to be a healthcare provider to register your business. So the many non-healthcare practitioners out there who want to be regulated, they want to comply, they physically can't without a prescriber. So there has to be a model put in place that allows practitioners to be registered, to be regulated, and without that bottleneck, if you like. I'm unsure how it's possible to even estimate how many prescribers we have. There's over 500 Healthcare Improvement Scotland clinics. Most of the prescribers that we know and collaborate with work perhaps part-time within the NHS. Some of them work in their own clinics. So it's finding prescriber availability to be in your clinic at all times is extremely difficult. If we then, we also can't rent space in another HIS clinic if you're not a healthcare provider. So for us, the regulation is very disproportionate, and I do believe that we need to find a way that includes qualified practitioners into a same regulatory system so that we can all be on a level playing field, committing to the same levels of clinical standards.
Okay, thank you. I think Tina's also wanted to comment. So you're out of my line there. Tina, would you like to come in?
No, that's all been covered actually.
Oh, well, there we go. Just very quickly on this point about prescribing, what would an ideal structure look like for you then?
Well, when we just look at Scotland and England at the minute, so prescribers can work from any location in England. Obviously, when their licensing scheme comes in, prescribers will be able to attend local licensed clinics, provide consultations, oversight, attend for adverse events. In Scotland, they wouldn't be able to do that under this proposed bill. If we're looking at creating a system that's equal over all the nations, I do believe having the same system everywhere it stops the confusion for consumers looking to get these treatments done. Ideally, if the model in England was adopted in Scotland, I do believe that there would be more compliance, there would be more clinics able to offer safe clinical space, they would have the availability for prescribers to attend. It would allow us to have links with potentially more prescribers than just having the one on site at all times. If maybe one wasn't available, you could source maybe others that are able to attend. But when it's regulated that you only have one prescriber in your clinic there at all times, it's very difficult to then find others if they're not available to attend. So ideally, having a system that would allow healthcare professionals offering or assisting in aesthetics treatments to be able to access local licensed clinics, or in the very minimum adopt a model through HIS that allows qualified practitioners to be registered in their own right.
Okay, thank you.
Patrick Harvey.
Good morning to the witnesses. Thank you, Convener. I wanted to come on to the theme of equalities. The Scottish Government has, as it does with all legislation, carried out an impact assessment on equalities. Several of the witnesses, I think, have made mention of the fact that a great many of these, the businesses that would be affected by this bill are female-led. I think, unless I missed anything, that might have been the only equalities impact that's come up in the discussion so far. Aside from that issue about the profile of providers of these services or people running these businesses, I wonder if I could ask you all to reflect on the range of equalities impacts in terms of people accessing or buying these services, whether in terms of gender, whether in terms of socio-economic inequalities, disability, impact on rural areas. And in reflecting on those impacts, if you could consider not only the access to these services, but also the safety, and whether the attempt to drive out what some witnesses have described as rogue operators and ensure a high standard of safety, whether that's a positive equalities impact in terms of the particular groups who might have specific reasons for accessing the services these businesses provide. And as I'm not in the room, I'm not going to point at anyone. If whichever witness wants to jump in would be very welcome.
Yeah. So as you mentioned, this industry is predominantly female-led. There are businesses in semi-rural and rural locations And again, these people have limited access to either prescribers or other means. There's lots of people will be affected, consumers and practitioners alike, from a range of different equalities. I think having a fair system to regulate the competence and qualifications of practice standards helps to support clinics in rural areas, and obviously the amount of female within the industry. If we're looking at a proposed bill that would potentially see these businesses closed, we're going to see, or the Scottish Government have estimated 1,500 clinics. Potentially that's just from businesses that they see with a kind of high street front. There'll be practitioners who are obviously going to have to close that are maybe not recognised at the minute within those figures. So I do believe that there will be some disproportional impacts on equalities throughout this proposed bill.
On this?
Yeah, I'm going to bullet point because I think we're pushed for time, aren't we? Yeah, back to female-led business and those carrying the burden of childcare. That is, yeah, a huge part of our industry. I think there has to be a look at quality in terms of what training is insisted upon in any bill. We speak about regulated training. We speak about one-day courses. Absolutely, there's no comparison. But there are also some excellent accredited courses out there that are the cost of those is far more achievable for people to be able to go and gain accredited qualifications. Regulated qualifications are lengthy and costly, so I think we also need to look at the insurance companies that are accrediting these shorter courses to insist that they meet a minimum standard so that training can be fairly accessed for everybody. I think that cost of treatments has to be considered as well. If this becomes a hugely costly exercise for businesses, then that burden of course will be passed on to the consumer. So it does have an economic issue because we will not be accessible for those that we're now priced out of their reach. And also we have an audience of clients that don't want to go to a medical space for treatments. They have a great comfort in visiting a non-healthcare or non-medical environment, and I think we need to support those clients, whether it's from an emotional perspective or for any other reason. There has to be diversity in the industry so that we can make sure that it's an equal playing field for everybody.
And Tina, I believe you wanted to come in.
Sorry, Convener, if I could just come in. Neither of the witnesses who have spoken so far have touched on the second aspect that I raised about the equalities impact that the government asserts will be positive in terms of raising standards and addressing the safety issues, that particular groups who perhaps would be more likely to access these services are currently exposed to that risk. And it touches a little bit on the points that Brian Whittle was raising around advertising. You know, advertising in the broadest sense and cultural pressures do impact on particular marginalised groups, whether that's around gender norms, whether that's around the way gender norms can be racialised. There's a range of different ways that these issues might push people toward accessing services. So could I encourage the remaining two witnesses who haven't spoken to touch on that aspect about whether the raising of standards is going to be a positive impact, as the government suggests, in terms of disadvantaged, marginalised or other equalities groups.
Tina, do you want to come in at this point? No, you're on mute, I think. No, we still can't hear you. I'll maybe go to Douglas first, so I always try and sort that out.
Yeah, thank you. So I think it's a really important point that all consumers have benefit from the same safety protections and have clarity around expectations. So a piece of legislation that kind of aims to raise the bar for everyone in terms of the safety that it delivers should be beneficial for all consumers, taking account of different kind of equalities considerations. I think there are a couple of kind of points that I would kind of just touch on in terms of kind of different groups. One would be, again, I guess to kind of refer back to that kind of advertising standards kind of authority and the work that they have around their guidance around the advertisement of non-surgical procedures and their desire for further engagement about how that they should deliver that in accordance with the bill. And I think that that is a good place to advance some of those more kind of detailed considerations about particular actions that might be required in that advertising landscape to make sure that particular groups in the population are being promoted to, if you like, in ways that are safe and appropriate for them. So I think there is a route through that kind of advertising set of advertising considerations to look at that. One of the other points that I'd made early on was about the provision of the opportunity to strengthen the bill around the provision of information that practitioners might be required to offer to consumers at the outset of a procedure. And again, that might offer an opportunity to think about whether there are particular dimensions of information of that information that need to be tailored to meet the needs of different groups in the population. That will require detailed work to think through what that looks like in practice, but I could see that as a mechanism by which that type of work might be undertaken.
Thank you. And I think, Mr. Harvey, if it's all right to go to Tina McCaffrey now, I think we've got sound. No. Unfortunately not. Back to you, Mr. Harvey.
Okay, I'm sorry that we can't hear from one witness. Obviously, as every witness is free to send us a written note after the meeting if there was something that you wanted to say that wasn't possible to put on the record. The government also asserts that there are mitigations that can be put in place in terms of the potential impacts. The government view is that there's a positive balance between the positive and negative equalities impacts, but that there can be mitigations for the negative impacts. Could the witnesses comment on what mitigations they believe will be in place or ought to be in place in order to ensure that we get the maximum positive equalities impacts and the minimum negative equalities impacts?
I think I would refer back to training again. I think one of the biggest risks in terms of equality from a practitioner perspective is that it would be a big leap for them to try and achieve, as Lindsay's already mentioned, to achieve that HIS regulation. So I think we need to look at how that risk is mitigated by looking at what the pathway might be and looking at alternatives in terms of levelling within HIS regulation so that those treatments that are less invasive require a different licence and structure to those that are deemed as surgical procedures. I think that is something to be considered. I think training needs to be looked at. There's a lot of discussion about regulated training, which I think is very important, but there's also excellent accredited training available too. So again, to mitigate the risk of people not doing any of it and becoming, those that are not following any regulation pathwork and working under the radar, we need to make sure that training pathways are accessible and affordable, and that needs to be looked at in detail too.
Yeah, so I believe that the current proposals disproportionately harm women within the industry, small independent businesses and practitioners from rural areas. So currently, right now, I do believe there is potential for harm in those areas. I think if there's a regulatory system brought into place that includes everyone within the sector, those equality risks would be reduced when all practitioners that have got qualifications can meet a regulatory pathway. And this obviously supports the businesses, it supports women, it supports the growth of the economy. And I believe then that consumers who are seeking these treatments out have the confidence that their practitioner has got qualifications. They're in a licensed premise or a regulated premises. So currently, right now, I do believe that there is disproportionate harm, and that's something that has to be looked at.
And I guess just finally to the Consumer Scotland perspective, is there confidence from your point of view that the approach that the bill proposes will reduce, for example, the disproportionate risk that people perhaps with low levels of literacy or other barriers to understanding what services are being offered and what they're being sold and what the risks are? Will the bill reduce that potential inequality of harm or risk that's being run by certain groups accessing services?
So, this is an area where I think there is more we can do on the bill, and that is by requiring providers to give that information to consumers as they go to undertake a procedure, and with a clear specification of what that information should be. And I didn't say this earlier, but your question quite rightly prompts it. A clear kind of guidance about how that information should be provided in terms of the accessibility of its content, in terms of the language that is used to describe those key bits of information to do with risks, to do with aftercare, to do with where people might go if they need to, if they wish to make a complaint or to seek redress. So that we think that there's an opportunity to strengthen the bill by there being a requirement that type of information is provided, and not just what is provided, but how it's provided. I think is an opportunity to strengthen the bill in the way that you describe.
Thank you very much. That's all from me, Convener. I don't know if you want to see if Tina McCafferty's audio has been sorted out one last time.
Well, I'm going to move to Elena Whittam because we've only got 9 minutes left of our session. But perhaps if Tina is able to speak, she can maybe address some of those other issues. Elena.
Thanks, Convener, and good morning to yourselves. I want to spend a little bit of time that we've got left speaking about enforcement and compliance. It's already been touched on quite a lot this morning. I had wanted to start with Tina, but I don't know whether your audio is sorted. And it was round about whether you support the offences and penalties proposed in the bill, and if not, what changes would you suggest, given that your submission to our call for review stated that improvement notices in education should come before criminal sanctions, reserving offences for deliberate or reckless malpractice. Now, Tina, I don't know whether your sound is back. Oh, it's not back yet, unfortunately. We'll ask that question to the wider panel round about the offences and penalties that are proposed in the bill. How do you feel about that? What changes would you suggest to them, if any?
So I do believe that effective enforcement targets unqualified practitioners and illegal or rogue injectors who are offering unlicensed treatment. Those are the people who are causing harm in the industry. It's not from qualified aesthetics practitioners. And although there is always a risk to all our treatments, those risks are extremely reduced when you have a regulated qualification in place. Now, across the sector, it's very evident that there are people offering treatments in unclinical spaces and using products that are unlicensed, and that is the people that we have to target. I do believe that sanctions that are in place are essential to limit how these people are offering treatments. But my concern would be, how are you targeting, how are you finding those people, what's in place to seek them out, because we know that they sometimes operate from their homes or from other premises. So I would like to know what measures are going to be taking place to actually enforce that and ensure that those rogue injectors are found and sanctioned.
So is your concern not really round about how the inspection process might happen with licensed premises, but actually the wider issue of those rogue practitioners who perhaps are not going to be caught under this bill? They are going to be caught under the bill in terms of the offences that they would be undertaking, but what is the mechanism for actually finding them out? Is that a concern?
Yes.
I can see that Louise is nodding as well. Yeah, Louise, I don't know if you
I
want
worry
to
that any regulation begins to regulate those that don't need regulated, if that makes any sense at all, and that there's those that will just fall completely out with the regulation, and those are the ones that we talk about that are delivering poor treatments and dangerous treatments. And I would like to see resources applied to those practitioners to limit their ability to deliver treatments, whether that's, you know, through local authority, you know, with the licensing scheme, or whether it's built into the regulation as well. How I would like to know how that can be targeted, because it's those practitioners that are giving the non-medical or non-health care that are trained the bad reputation, and that's really unfair.
So is there a concern in there as well around about a safety paradox that we could potentially be seeing in that, where we're seeking to actually raise safety and standards, that we could see that part of the system grow a little bit?
Absolutely.
In terms of pricing some people out of the market, and then they turn to that area if that area is not regulated effectively?
Most definitely.
Okay, so do you have any suggestions as to how we could ensure that that part of the market, off-market, black market, whatever you want to call it, is effectively regulated under this bill?
I think there needs to be resources allocated to looking at that, and I think we also need to look at the consumer and making them aware of what is good practice and bad practice, and then hope that the consumer will ultimately regulate the market in that way by not choosing those or by reporting those.
Okay, Douglas, do you want to come in from a consumer perspective?
Yeah, briefly. So I'd go back to that kind of three-pronged approach that I talked about kind of early on in the session. The raising public awareness and the consumer information, so that consumers know what regulation looks like, they know what they should be looking for, so they know what to spot, and they know when it's not there. That's really vital. There's the discussions that we've been having about that pathway to compliance, so support for businesses that do want to comply with the new regulations to get there, so that they're being brought on that journey. And then the third element is enforcement, so that those that are choosing to stay out with the new regulatory system, that we have sufficient resources within the enforcement mechanisms to find those operators and to apply the appropriate penalties.
Okay, and I suppose the final question for myself is round about whether there's a belief that we should have a system whereby you have improvement notices that would need to be issued first on a path to compliance thereafter, as opposed to moving directly to sanctions and criminal charges, and also whether there should be a legal route for appeal and statute as well.
I do believe that if there's any clinic has been inspected for any reason and they're found to not be complying in certain ways, then I do believe that a notification would be appropriate. I think that happens just now across regulated clinics. However, I think it would depend on what they were actually doing that was wrong.
Yeah.
So I think that's a very difficult subject at the minute to put into words when, again, we're focusing on the bad practice. And I think it's extremely, if we look at the real industry just now, there are members of the public who are quite happy to go to someone and receive botulinum toxin from unlicensed sources. They've had no complications and they're happy, and they will continue to do this. With this regulation in place, we are looking at making sure that consumers across Scotland have access to safe treatments. But I do still believe there will be people continually going down the black market route, and we need to develop some kind of resource to figure that out and put a plan in place to get rid of the people who are creating the most harm within the industry.
Okay, and yeah, Douglas, just finally.
Not a detailed view on the kind of pathway that you were specifically setting out, but what, as you all know very well,
Your mic just came on, sorry.
Oh, sorry.
Your mic's not on. But it's on.
Apologies. As in, so not to kind of give a kind of detailed view on the particular options that you were setting out, but to say that there are, of course, lots of models of good practice and probably practice that has been less successful in a whole range of other sectors and industries about how to achieve that high level of compliance, and further work to examine the transferability of some of that learning to here, I'm sure would be useful.
Okay, that's very helpful. Thank you. Thank you, Convener.
Thank you very much. Can I thank the panel for their evidence this morning, and I'm going to briefly suspend this meeting for a changeover of witnesses. We will continue agenda item 2 by taking evidence from a second panel of witnesses on the Non-Surgical Procedures and Functions of Medical Reviewers Scotland Bill. Our second panel comprises representatives of the cosmetic procedures industry. And I welcome to the committee Leslie Blair, Chief Executive, British Association of Beauty Therapy and Cosmetology and Confederation of Beauty Therapy and Cosmetology, and Victoria Brownlee, Chief Policy and Sustainability Officer, British Beauty Council. And we'll move straight to questions. And Emma Harper.
Thank you. Thanks, Convener. Good morning to you. So you may have heard some of the first panel in responses to the questions that we have. This is our first evidence session. So I'm just going to open it right up and ask you what your views are on the proposed model of regulating non-surgical procedures as set out in this bill for Scotland.
I welcome it as a starting point. I think that for it to be successful, it does need obviously a bit more bones about it. In order, if we're going to do it, we need to do it right at this stage to get some sort of oversight in our industry. I think so. If you would like me to go into deeper, I will, or I'll let Victoria talk now. But just like as a starting point, I think it's very, very welcomed in our industry. It's needed in our industry. We're in a ever-evolving industry. Things are changing so very, very quickly. It's very difficult to keep it up. I think things have gone quite askew over the last number of years, and it is very, very welcomed, I think, especially from governing and regulatory bodies, that we have some sort of oversight in place.
Yeah, pretty much second that. So Leslie's been working on this for many more years than I have, probably since the Kira review in 2013. But we, as the Council in particular, have been working on regulation in this space since we were started about 6 or 7 years ago, and have been working really closely with the UK government in a lot of the work that they've been doing in that space. So we absolutely welcome regulation in aesthetics, non-surgical cosmetic procedures, as I feel that it's essential for professionalising and raising the standards and reputation of the industry.
And what role do you think that Healthcare Improvement Scotland or other industry bodies have in setting up safety standards for practitioners who are, needing to be trained and regulated and supported?
Well, I think that we need, as I said previously, we need the oversight there for us all to adhere to. I think Health Improvement Scotland obviously is predominantly for healthcare professionals. I think we're needing some sort of licensing model for non-healthcare professionals, because that's very, very important, and that takes up a lot of the treatments and modalities that are being performed on a daily basis. So I think it's just important to set it up so that we get some parity there. That I always believe that everyone should stay in their own lane and work to their own capabilities and their own qualifications that they have, etc. But I think that we need this oversight there. I think a lot for consumer awareness. Consumers don't know what they're asking for. They don't know what they're looking for, a lot of them anyway. So I think sometimes we need something there that is going to educate the consumer and to educate everyone out there as well, and to give people something that they know that is going to be followed, and that's from the consumer to know where to go, and from the practitioner to know what they should be doing and what they shouldn't be doing as well.
I think the accessibility of the treatments that we have now has made it somewhat more of a frivolous procedure than perhaps it had been seen maybe a decade ago. So therefore, regulation and oversight from someone like Healthcare Improvement Scotland is really vital to hit home that the fact that these are risk procedures. There is a risk of complication, there is a risk of things going wrong. And so you need those mandatory standards in place, one, to check the practitioner is actually fit for fit in terms of standards, training, competency, but also that the premises themselves are safe, hygienic, that the person going to have the treatment knows that they've been inspected, and that there is recourse essentially if something should go wrong. And what we have at the moment is a system where, unless you're a healthcare practitioner, you do not have that for the vast proportion of non-healthcare practitioners are often offering these kinds of treatments as well.
And we have no accountability for the non-healthcare professionals, so there is no recourse if something goes wrong. If you're a healthcare professional, you're accountable if something goes wrong. You can be struck off from your association, etc. Non-healthcare, that's not the case. So we would like to see that as well, and that is going to raise the standards within the industry as well.
Okay, and just to touch on the, I know there's a hierarchy of procedures from non-invasive to more invasive. Yeah. Over the weekend I read about someone who the eyebrow wax was so hot, yeah, and it should not have been applied to the skin, but, yeah, it caused burns to both of the person's eyelids. Yeah. And so, you know, as a former operating room nurse, we would check the temperature of the water that we were going to use, or the saline for irrigating an open abdomen, for instance. And so they had processes in place. Yeah. And so I'm interested in the whole consent process, yeah, of risks, benefits, yeah, alternatives, absolutely, then the documenting of that, and then and it might be touching on other people's questions, but the whole tracking of that kind of conversation in order to make sure that consumers are aware of what it is they're accessing when they're accessing treatment.
Yeah, I think I'm really glad you brought that up, Emma. I was a practising beauty therapist for over 30 years. I just stopped just before COVID, just because other work gets in the way of it, unfortunately. But it's very, very important, and to go through the proper qualification and regulated qualifications. I know we were talking earlier about some accredited training against regulated qualifications. I'm very, very much for regulated qualifications, because I think there's a benchmark there to national occupational standards, so then we can be assured of the quality of the actual qualification given, because there is that examiner or the examination at the end that we are reaching that national standard. I think that anyone who has done that should know, let's use the waxing, that if somebody, when they came to me, I would go through a thorough consultation with them to make sure they are not taking any, or using any retinols, that they're not taking Roaccutane, because all of these things would cause like skin thinness, blah, blah, blah. And I would document everything on the consultation. I would test the wax on myself. I would test the wax on the client. I would have the client sign the consultation to say I've done all of this. That's very, very important to have all this there. Now, as an insurance company, which we also are as well, that is part of our code of practice and good practice guide, that you must do this prior to treating the client and on every single visit. But let's be honest, how many times have you had that when you go to have treatments done? I go to places and it doesn't happen. I've got to ask for it to happen as well. So this is very, very important. And I think this is where the bodies like of ourselves and British Beauty Council, we can be out there educating our members and educating the industry. And that's what we do on what is good practice there. And that's what we try and do every single day.
Mm-hmm. Final question, Convener. Just what effect do you think this bill will have on the reputation of the aesthetics industry? I hope
it raises it. I really do, and it needs to be raised as well, because we spoke earlier about Wild West charlatans that are out there. It's happening all over the place because of how quick the industry is moving forward. It has been allowed to get there, but that isn't a reason for us to leave it there and to allow it to continue. I think we've now got to step in and make sure that the standards are there. There's lots of questions, there's lots of different research we're all going to have to do, etc. But it's just so, so important. And I think that the majority of professional, regulated, qualified people are absolutely welcoming this with open arms.
Mm-hmm. Yeah, I would agree with that. I think it's absolutely welcomed. The bill itself, I think, is quite thin. It would be good if there was much more around training, education, supervision and oversight, a little bit more tightness around the type of healthcare practitioners that can be regulated to be able to supervise and oversee people having treatments in their premises. In the UK regulation, for example, it's simply only the NMC, the GMC, the Nursing and Midwifery Council, and pharmacists and dentists. There's quite a substantially longer list of regulated healthcare regulated organisations that are allowed within this regulation, which I think is probably too broad for what we're talking about. Because ultimately, we want a person supervising or the person that's overseeing it to be trained in the modality and have deeper knowledge and understanding of the modalities that they will be supervising.
Okay, thanks. Thanks, Convener.
Sajid Gohani.
Thank you, and just declaration of interest as a practising NHS GP. Thank you very much for appearing today. I think, Victoria, given what you've just said, we were asking exactly the same questions about the bill in private to find out why this list of regulators were the case that it was. But I'm very interested to know, to speak a bit further about consumers and what they don't know. So when they go before a doctor in a GP practice or in hospital, you kind of know a standard of what you're going to receive. But when you go to the beauty industry, you don't. So things like your botulinum toxin needs to be in the fridge between 2 and 8 degrees. And vaccines do the same, but you have to prove the medical grade fridge and prove that this is the case. But that doesn't necessarily happen everywhere, does it?
Absolutely not. Just as a declaration of interest as ourselves as well, we have been very clear from the outset as a council that we only think the healthcare practitioners should be offering injectable procedures. So I'm completely with you and in support of the concerns that you have. I think we know that there are perfectly competent non-healthcare practitioners that are training, but we can't have the guarantee that that competence is across the board. And also when there are instances of adverse reactions to injectables, I don't feel that they have the competency and knowledge and availability of prescription-only medication to deal with complications should it be needed, to be able to deal with that as swiftly as is necessary. And so if we are saying that the risk to the public is the primary focus of this regulation, then absolutely we can't have non-healthcare practitioners touching injectables, in our opinion.
And just back to the point about consumer confidence and consumers knowing that they get a basic standard, if we have this regulation in place, will that ensure that reputable businesses that follow the code and do get inspected will do things like ensure that their products are kept at the appropriate environment, ensure that the people providing treatment have a basic level of competence?
I think it will come down to enforcement, and that's always the concern with all of these things. We can have the most robust regulation that there is, but if there's not adequate resource and funding given to really robust enforcement of this, then who's to say with that? We would very much hope that the inspection process, that the ability to educate the public through a public education campaign, which, as Leslie's rightly said, we would be absolutely supportive of being involved in, would educate the public of these are the kinds of things that you should be looking for when you are going to a premises. But the proof will essentially be in the pudding and the actual enforcement and enactment of this regulation when it comes in.
Just on premises, so we heard from the previous panel about people performing procedures at home in their garden sheds, or not sheds, sorry, pods.
Yeah.
And that would be put at risk. Now, in my opinion, if you are providing a procedure, you need to be doing that in an environment which is clean, the ability to wash your hands and have levels of hygiene, which is what his premises would provide. And you could still make that a comfortable, homely environment.
And let's not... I think there was some concerns I had with the previous evidence that was given around removal of livelihood. There are still hundreds of procedures that can be offered to consumers that people from levels, and Leslie, you'll be more knowledgeable for this than myself, levels 1 up to 4, 5, up to 7 can offer that aren't within Schedule 1. So, yes, there will be limitations to the procedures that non-healthcare practitioners can offer. No one's arguing that. But in our opinion, for public safety is number one priority. They shouldn't be doing those anyway, in our opinion, unless there would be very, very strict oversight in certain ones in the schedule, not necessarily all. So for us, the idea of them being done remotely, mobile, in pods in people's back gardens is completely against what it is that we're trying to do here.
And sorry, did you want to?
Yeah, I was just going to say, I think we're asking for parity and an even playing field from the beauty therapy side, but also from the medic side as well, that if medics, healthcare professionals have got to jump through hoops to have the proper ventilation, the proper cleanliness standards, just all of the things that is involved in being an HIS clinic, then it remains very, very unfair that non-medics are not having to do that, and that's the situation that we've got just now. And I totally agree with the working with the cabins, etc. There's some amazing businesses, absolutely amazing, but I think we need to have certain procedures in certain premises that are overseen and regulated from our perspective as well.
And my final question, do you believe this bill will provide, because we heard in panel 1 that there is no mechanism for recourse, do you believe this bill will provide people with a mechanism for recourse if something were to happen? And if not, what would you do?
Yeah, I would say not at the moment, the way that it's sitting at the moment. I think it needs some kind of meat on the bones with it. And it's just about giving the non-healthcare professionals this accountability. I think that is going to make, and I think the panel previous to us would totally agree with that as well, that we are wanting it to be a level playing field across the board here. So having that accountability is going to make a massive, massive difference. But I think we need to work on what's here. This is, as I said, it's fantastic. It's a great start. We just need to make sure that everything is in place. The training, the education, the premises standards, the observing supervision, etc., just needs to all be very much succinct and part of this as well.
If you could write to us with just your suggestions.
We absolutely can. We can. You'll be sorry you said that.
Brian Whittle.
Thank you, Convener. Good morning. I've just got a question out the back of the previous panel, and listening to them, it seems to me a concern around collection of data, or lack of collection of data, especially around any complications that may have arisen from any kind of procedure. If we as part of this bill developed a system where we collected that data and deployed that data properly, would that not in itself help to develop a system where those operators who are operating a really good business would be highlighted? Would we be able to start to weed out those ones that are giving the system such a bad reputation at the moment? It seems to me that there's a real lack of collection of data.
Yeah, I think there absolutely is a lack at the moment. I think because there is no need or no requirement to do it from a legal perspective, that's why it's not being done. And I think that it should be a matter of good practice. However, that's not what we're having a lot in the industry at the moment. So I think that if that were to be part of a mandatory requirement, then I think it can only help over the years for us to build up data and for us to be able to assess really as well who should be doing what, where should it being done, and let's look at patterns to see what is going wrong. We do very similar with insurance for the lower level modalities, likes of what Emma said about waxing, etc. Now we do notice that there is a correlation between people that do not have regulated qualifications and claims. And it's higher for people that have not got the regulated training. We now don't insure them, so we don't get to see that data as much, but our claims are down because we only insure people who are properly qualified.
Okay.
I think we know at the moment that the NHS has to scoop up and deal with a lot of complications and problems that arise from things going wrong, but that at the moment there's no single reporting system for making sure that they're all reported in the same way, so they could be presented if they come in through A&E as 3 or 4 different kinds of reasons why they're coming in for that. It wouldn't necessarily be recorded as something necessarily definitely to do with aesthetics or non-surgical cosmetic procedures. So that in itself is an issue. If we could have some kind of universal system for recording in that way, but then we know a vast majority of complications, they either go back to the practitioner, or if they don't want to go back to that practitioner, they'll go to somebody else and ask that practitioner to fix them, essentially. And there's a real reticence in the industry to fix somebody else's work, and I know that probably happens in the health profession as well, in the private sector. So yes, we definitely need a much more universal system for how we track and deal with those complications when they arise. But it's also important to say, and I'm not trying to be a defender here, but some of the complications that come aren't as a result of negligence or fault on behalf of the practitioner. Sometimes it can be that the person has an allergic reaction, or they haven't disclosed certain information, or various factors. And so it's not necessarily a reflection of incompetence of the practitioner.
but you'd be able to record that as...
Yeah, absolutely. The more data, the better, don't get me wrong. The fact that we haven't had data has meant that we've been able to kick the can down the road for many, many years in this issue. And I think it's something that we recognise and have been pushing for many years as something that we really want to push forward with regulation. And the fact that we haven't had that data has made it increasingly difficult.
Patrick.
Thanks very much. Victoria, you mentioned earlier a difference between the regulations that are going through in England and in Scotland. And I think certainly I'm sympathetic to the suggestions that you're making about how we could make the proposals for Scotland more robust. There's obviously other differences, so I just wonder if you could give us a thought about the other differences where you think we're getting it right, or is other things from the UK system that we should be looking at?
I think where Scotland are now is a kind of where the UK was with the Health and Social Care Act back in 2022, where they put in the secondary legislation to give the Secretary of State powers to bring in a future licensing, blah, 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 blah. That's kind of where Scotland is going with this bill, with a few slight changes. But what's missing currently within the bill in Scotland is that secondary section. So in the consultation of this, in regards to what was going on in Scotland before, we had this group 1, 2 and 3. And that made it really, really clear. What we're looking at in the bill is basically kicked out of the water. The Schedule 1, 2, groups 1, 2 and 3 don't exist now. And as a result, we have the much more common, much more widely being done lower level procedures, currently having no level of regulation under the proposals within this bill. And what we've been fighting for years is a licensing scheme. The enforcers, the people that work in environmental health, trading standards, etc., are crying out for regulation because they know that there is dodgy practices going on in their local authorities, and they currently do not have the teeth and the powers to be able to close those people down. And so they have been coming to us saying, please help us. We have been going to the government and saying, please bring something in that gives them better enforcement and prohibiting powers. And the moment we don't have that, and my worry with this bill is that, yes, we absolutely welcome that those high-risk treatments need immediate action, and it's good that we're moving in that space, but if we haven't dealt with that secondary part, which has significant volume and people having those procedures every single day and things going wrong in that is going to be able to continue to take place, and that's a concern of mine.
Are you able to tell us what sort of procedures you're talking about that won't be regulated by this legislation? But
so it's all of the is it
the peel, skin needling, radio frequency, non-ablative laser.
Yeah, heat and cold.
Yeah.
I could send you a list after.
So I think that'd be useful.
Yeah.
I mean, I think we thought some of those things were covered, so it'd be useful to know what you think is not covered.
It's more of the, so in England, they, of course, it's going to be different, but they do a red, amber and green. So they have procedures within green where you still have to have a licence, but there's not a supervision element of that. At the moment, there's no provision within that, within what Scotland's proposing here. And there's certain lower level amber treatments in the England regulation that isn't in this bill at all. And that's where we talked about supervision earlier, that we can't, in our opinion, you can't have a one size fits all when it comes to supervision. There's going to be some things that require a person physically in the room overseeing a procedure when it takes place, compared to something which is much lower risk but does still require some level of supervision. And that just might be a listed person that can be on the other end of a phone should something go wrong.
So it'd be really helpful if you were able to kind of write to us, highlighting that, and make it probably easier for us to digest. Leslie, did you want to add anything else about the kind of differences the two systems?
No, I think Victoria's the policy person. You're very good at deciphering all these.
Which you probably would say anyway. It's that there's no stipulation within this about what the education and training should be. And we can say, until we're blue in the face, that a Health Improvement Scotland premises can only offer these certain types of treatments, but ultimately there's still going to be non-healthcare practitioners potentially offering these treatments with supervision, but there's nothing to say that that person has to have a regulated or accredited qualification, what the supervision and training requirements are of the person doing the supervision and oversight. So just because a person has been an optician or a chiropractor or what was the osteopath, they shouldn't necessarily be able to oversee botulinum toxin injection. So they have to have the correct level of training for the modality.
I think that's really helpful. You've put that on the record. It's something that, again, we were talking to the Bill team earlier.
It's very, very important that, whilst we want everyone to have access to be able to train for these different modalities and treatments, you've got to have the prior knowledge in order to do the stepping stone to do so. So I think, just as you said there about an osteopath, their path should not be the same as another medic should be to do it, and the same as it wouldn't be the same as a beauty therapist, because we would need to do more anatomy, etc., in order to get us in the place. Into the place to be able to perform these modalities. So I think that's really, really important. But also, conversely, from the medical point of view, that we don't agree that somebody, just because they're a doctor, should be able to do skin peels after half a morning of training, when we are asking that, you know, that there's a regulated qualification in place in order for the beauty professionals to do it as well.
I mean, I suppose some of the detail that you're asking for might be things that could come in secondary legislation or in regular, other guidance, but it's useful you put it on the record. So thank you so
And
much.
if you're going to do that, we really need a clear timeline of when that happens, because otherwise this will be flawed. You need at least an understanding of those things are going to come by X and some kind of commitment in that space. Otherwise, they're kind of pointless.
Yeah, thank you.
Brian Whittle.
I think some of the questions I really wanted to ask was around how we regulate advertising. That whole idea of what the demand, what is the driving for the demand in non-surgical procedures, being realistic about potential outcomes, especially among the younger generation, I think. And how do we regulate the advertising? How do we make sure that there's potentially mental health issues around there? And I thought it was really interesting in the last panel, because they said, that as part of training, that would be taken into account.
Of proper training.
Proper training, that is taken into account, and there are those operators out there that are operating exactly the way they should be. Ethics is, not a black and white.
No, I think it's very, very important. When I did my training over 30 years ago, when I was in primary school, obviously, that was very, very much indoctrinated into us about body dysmorphia, about ethics, about standards. It was just so important. Now, with the inception of 1- and 2-day courses out there, they're just very, very quick. They're very much just get in, learn how to do the treatment, and then back out again, because people are wanting to make money very, very quickly. So we are not getting as many ethics in a lot of the non-regulated training that's out there. I think from the advertising point of view, to bring it back to your original question, with the growth of social media, TikTok, and everything that else is out there, all the different social channels, we are getting unrealistic expectations out there, especially young girls. It really, really worries me of what their ideal of beauty should look like. And it's all filtered. It's not how actually people look, but they think that that's what they've got to look like. It's raising mental health issues, that they are going to get treatments done, and unscrupulous practitioners are actually giving them treatments and they don't need it. So I think that a lot of the blame does lie with the practitioner as well, that they should be able to say no and not do a treatment that they did not think that was right for the client, patient, whoever it is that's in front of them. But I think the social media has got a lot to answer for. I know the advertising standards, you're not allowed to advertise wrinkle relaxation injections, botulinum toxin, because it is a prescription medication. But for fillers, because they are a medical device, yes, you actually can. And I think that there needs to be some oversight, and I don't know how we do it. So, but I think that, sorry.
I think the issue that we have is that the ASA would argue that the regulations that they're already trying to do this, but we know at the moment it's essentially reactionary rather than anything proactive. That when people do advertise things that they're not allowed to do, there's very little recourse. There's not very short level, low level banning for maybe a couple of weeks or something like that. They're asked to take the post down. They're given several warnings. First, I think you need a much more robust system that there is penalties for misusing advertising, putting advertising up that's unsuitable, but also greater penalties on the social media companies that ultimately, I don't know if you've been through your feeds recently, your avid Instagram user, but every other post now is an advertisement. And so the accessibility and the visibility of advertising now is so much more prolific than it was even a couple of years ago, that you are unconsciously ingesting all of this information all the time. So it comes back to what Leslie was talking about, how whether you realise it or not, the advertising is going in. Like you're being influenced by it, and the fact that we'll watch there's a lot more reality TV out there than there was previously. It means that these unrealistic body images are being projected by people that generally go on these shows, and then they're subsequently selling or promoting these products throughout their social channels afterwards with, again, very little checks and balances that they are saying the right things or doing things correctly. That's technically advertising as well, but just because someone famous is doing it, it's not necessarily seen as that.
I think in that respect is why it's so important that the practitioners are held to a high standard, because they're ultimately the ones who can say yea or nay to that procedure. So I suppose then it's a resource issue. Then it's all very well saying, here's the standards we want you to stick to. How do we enforce that?
I was going to say that this can be self-funding as well, because if we've got a licence scheme in place and there's a charge for that, that's going to raise revenue, and hopefully some of that could be pigeonholed for the advertising side of things, because I think, there is a lot of false claims out there. But I think just remembering more awareness to what can go wrong needs to be communicated to people out there as well, because I think people do not understand what can go wrong, that you can go blind if a filler goes wrong, you can lose your lip. I've got some fantastic photographs that I show to friends when they're going to go and get things done of somebody with half a lip and it's all kind of melted away. Show that to somebody before they go and get a procedure, then they are going to think twice about who they go to and go and get it done, just because they've seen somebody advertising it for £50 on TikTok or whatever. I think it's just really, really important to educate people in what can go wrong.
Well, you've certainly made so I'll think about it twice before I get my lips done. Convener.
Aaron Walken.
Have answered some of the questions that I had. It's really around training and competency. But just to be clear, there are voluntary standards we've been told that support regulation and improve safety. Do you think that is the case, or do you think that we need to have mandatory training, qualifications?
100%. We are self-regulating as an industry body. We have now decided and taken a massive commercial decision of we won't insure you unless you have a regulated qualification. But unfortunately, just because we are not doesn't mean to say everyone else is. And most insurance companies are commercial. You don't need to be insured to carry out a lot of these modalities. That needs to be, set in stone, that you need to be insured. That's very, very important. But I think that with all of this, that you don't need a qualification to be insured. You can just get out there. You can go and do one day's training and then be out practising. So you could be working in the bank one day. The next day you can be doing some quite high-level treatments out there. So this is what I would like to see going away. I think one-day courses, accredited training is so important for our industry, because our industry is ever-evolving and we need to continually develop. So what I always say is that you need the base. You can't build a house on sand foundations. You need the regulated qualification there, and then to build on that, that's where your accredited training and add-ons and everything is there. Just because you've got a sparkly certificate doesn't mean to say that you're actually qualified and able to do a modality. Everyone laughs when I say all that glitters is not gold. It's walking into salons, seeing certificates up there, oh, they must be good because they've got a nice shine certificate. This is why we need regulated training, Ofqual, SQA, that there is a benchmark there, National Occupational Standards, it's all set in stone. At least we have then got that benchmark that people have got to adhere to. Some of the accredited training is fantastic, it really is. However, it's not got the same oversight there, and we just can't monitor it to the same level. Very, very important as an add-on, but not a standalone.
And I think just building on that, the regulated qualification is important, but also is regulated or approved providers. Yeah. Because, yes, you could have as many voluntary registers as you want, but if there's no legitimacy or competency from the provider, then really it's not worth the paper it's written on. And we've seen a proliferation of all kinds of training providers put themselves out there and essentially prey on people that, as has been mentioned previously, have limited income and are in good faith going and taking a qualification that they think will then make them fully competent in 2 days in injectables. Absolutely not. There's a reason why the course is taking 4+ years. Yeah. It's because you need that time, experience, levels of competency, discussion on safety, risk, anatomy, etc. All of the things that all encompass. There's a reason why it's taking that long. But yet they're being sold a product for £5,000, however much, and are taking that and saying, well, if somebody's with, you know, these numbers after, these letters after their name are saying that that's okay, then that means it's okay. And unless we have something from the Scottish Government that says, no, these are the only providers that can provide this, or only people that are offering this particular type of regulated qualification can be a training provider, then unfortunately we're just going to continue a situation where we've just got hundreds and hundreds of different training providers.
And it's the use of certain terminology as well. We're seeing it a lot just now, the use of the word level. We, as an insurance company, constantly get people sending in their certificates for us to insure them with level 1, level 2, level 3, level 4, level 5. And when we check, it's just the play of words. I would like to see the terminology that's a protected kind of phrase for education. Also, the use of the word qualification, that is my biggest bugbear. That a qualification is something that is a regulated training, etc. I would say that an accredited training is not a qualification. And I always say that to people when we're discussing. They say, oh, I'm qualified in this. Well, no, you've done a training in it and you've done a course and you've attended a course. You don't hold a qualification in it. And I think it's just getting that terminology out there is really, really important as well. For the consumer as well, we had an event actually at Parliament, you were there at the beginning of the year, up here, just about consumer awareness, because we need to educate the consumer in what they've to look for as well. I can send you all details on that as well.
That's great, that's lovely, thanks. All my questions are answered. Thank you, Convener. Thank you.
Carol. Paul Sweeney.
Thanks, Convener. Thank you to the panel for coming today. Just want to touch on what was discussed in the previous panel around this kind of tension between a level playing field for consumers and confidence that the services are of a certain standard and the barriers to entry for smaller independent home-based businesses. What is your view on that balance, and how could regulation be implemented without disproportionately affecting smaller players in the market?
I think it goes back to what I was saying previously, around being certain premises that are suitable for the levels of treatments that we're talking about here. The higher the level of risk, the more likely it is that that needs to be taking place in more of a clinical environment. And so unfortunately, whilst I completely welcome the ability for people to diversify and offer treatments and services in their homes and mobile, whatever, if they're doing so in a way where they are fully qualified and in the provision that they're undertaking, there are still certain treatments, in our opinion, that shouldn't be being given by those people. And as I said before, there are still a plethora of other treatments that they could offer that fall within the range, within the qualifications that they will have received.
Would you be able just to go into a little bit more detail of what that split should be, what the hierarchy of treatments might be in a certain setting?
I was going to say that one that we are continually trying to advocate is that anyone who is performing a treatment should be able to manage their own complication, or they have the person in the same building or with them. I know that it has been cited to have the prescribers that they can be a phone call away, etc. But you can't account for traffic, an accident, a puncture in your car on the way to clinic or whatever. So I think for us, for the higher level modalities in the more clinical setting, if you have the correct qualification, you have the correct oversight, then it's fine to do. Can you do that working from home or working from mobile? I don't know. At the moment, I would probably say not. I think it's just important, I did say earlier again, everyone to stay in their lane and to do what they're able to do and what not is comfortable, but I think the correct clinical settings are very, very important. And to go back to the point that I did make at the very beginning, if we're asking the healthcare professionals to pay a large licence fee to be covered by Health Improvement Scotland and they've got to tick all the boxes, etc., other people doing the same modalities need to be following the same levels of enforcement and oversight as well.
That's helpful. I just wonder if there are mitigations that could be designed, such as support for training, so that individuals could develop their skills to meet the regulatory requirements that would be introduced. Also, the issue of facilities, which has been discussed in the logistics, whether there could be access to common clinical space, a common user facility, how that might be actually developed, and
Yeah.
what's your view on how that could happen? And
Yeah,
it's one thing to say it would be a nice idea. How do you actually?
Yeah, but
create the incentives?
there's no reason, well, please correct me if I'm wrong, but there's no reason why a cabin in somebody's garden, can that not be an HIS clinic as well? You know, so there's no barrier there. I think it is just having the correct standards for everyone. You know, we're asking for parity, but it has got to be parity across everything. You know, we can't have it always. I think, you know, it's got to be there. But I think that everyone should have access to the training. I know that what we're doing just now, we're working for for skin needling, skin peels, laser, etc. We're working with a number of colleges to do some sort of shorter training, but just to be that maybe you would go to a centre, be assessed to see what your competency is, see what is missing from that in order for you to gain a regulated qualification, and for the person to only have to do that so that they're not going to have to retrain. You know, there's a lot of very, very good operators out there just now that have maybe been doing these modalities for 10, 15, 20 years. To ask them to go back and retrain to get a certificate is probably quite onerous. However, we've got to be assured that they are meeting that national standard. So there is ways of doing it. We are working with centres just now to make that transition much, much easier for people from a financial, from a time perspective, because a lot of people are working full time. We did hit on that this is a predominantly female industry. I think the survey that you did a few years ago, Victoria, 88% female workforce in the UK wide, and 80% business owners are female in the beauty industry. So it's important that we support that, but safety must be of paramount. We've got to ensure that the safety is there.
And I was just going to add to that, sorry, that I absolutely do have sympathy that there should be a route to get the professional level of standard of qualification to be something like a prescriber, for example, without having to accumulate, and I know it's slightly different in Scotland, but several hundreds of, potentially tens of thousands of pounds worth of debt if you're not practicing, going to university in Scotland, if you through going through a healthcare practitioner route. And so I would really like to work with the regulators, government, etc., to look at ways where we can find a more accessible route. But and as it currently stands, a level 7 is meant to be a master's level. Master's level qualification, but I do still think that there needs to be additional mitigations in place to ensure that there's more of that clinical level of safety, which ultimately we're not experiencing every day necessarily in a beauty professional environment.
No, and I think that's really, really important to see how we can get everyone to that level, because what we don't want to do is be encouraging people to go and do a nursing degree only to then leave and come into aesthetics, because then there's the burden on the NHS of paying that and then not getting the benefit of it. So I think if we could work together and do some sort of aesthetic nursing training, that they don't need to go through the full medical degree of being a nurse, but going through all the very, very important parts in order to manage complications for all the different modalities that they'd be doing as that aesthetic nurse.
Do you have a view on potential unintended consequences of the legislation, particularly around driving behaviour underground into an unregulated space, or even overseas, or to different jurisdictions, even if there's a difference between Scotland and England?
Yeah, I think that's why we need parity between Scotland and England. It was very apparent during COVID when we had, I think we called it Maskgate, that in Scotland, obviously, you were wearing masks a lot longer. England, you weren't. People were going cross-border for treatments. So I think if we can avoid that as much as we possibly can and have as much parity there, that would be really, really good. I think we're never going to avoid driving people underground. I think we are. But I think as long as we can make things as robust as possible to make the enforcement fair but firm, I think that's very, very important as well, that we would get a lot of buy-in from it. And I think people would train. I think people fundamentally want to do the right thing, most people anyway. Yeah. Hopefully.
It was just very quickly, Ms. Brilling, you mentioned about this kind of idea that certain treatments you don't think is appropriate in certain settings. Can you just give us a couple of examples of what you're talking about, just for my own clarity?
Sorry, repeat that one. Can you just
You
repeat?
mentioned in your initial response to my question certain treatments you didn't think were appropriate to be carried out in, say, a home setting. It was just, could you give me some examples of what you're talking about?
Yeah, so injectables would definitely be within that, anything where we're intravenously injecting. So there's been a massive surge in kind of vitamin injections. If you're hungover, go and get a vitamin injection, or weight loss injections, which are administered by a clinic practitioner as opposed to by the individual themselves. Those kind of, anything injectable based, I personally just don't think should be done anything other than in a clinical setting.
Okay, thanks.
Patrick Harvey.
Thanks very much, Convener. Good morning. Just about morning still. Good morning to witnesses. I wanted to come on to the equalities impacts. A number of questions on this, which I discussed with the last panel as well. I think a moment or two ago, Leslie Blair was talking about the number of women-led businesses that are in this industry, and followed that up very firmly by saying, but safety is paramount. So I'd like to explore that balance a little bit. The last panel were quite clear on the positive opportunities for people providing these services, and in relation to wanting to ensure that there was still access to these services. It was a little bit more difficult to draw out from the last panel some of the disproportionate risks and harms that particular groups in our society might face at the moment. So could I ask if you agree in principle, first of all, that a completely deregulated free market approach to this issue would reduce the inequalities of business opportunities, and it might reduce the inequalities in terms of access to treatment, but it would massively exacerbate the inequalities in terms of harm and risk? And how do you feel or do you agree with the government's position that that this bill strikes the right balance in terms of mitigating some of the negative equalities impacts, but the government's view is that the positive equality impacts from the bill outweigh those that are negative?
I think for me, I'll come back to safety must always come first. I think that's got to be our first decision in anything that we do. And I think Victoria very eloquently went through about if you have trained throughout the different levels, there's lots of different things that you are able to do. We are not advocating at all that anyone is not allowed to do anything. What we're saying is make sure that everyone is trained to an appropriate level and qualified to an appropriate level. And that might be that if you are wanting to train in injectables but you don't want to go down the medical or the healthcare route, then you're going to have to work with a prescriber. If you don't want to work with a prescriber, then you are going to have to go down the medical route to become a prescriber, etc. So I think there is absolutely no barriers there from restricting any training to anyone. So I think that what we need is, again, going back to the beginning, we need a level playing field. We need everyone to be qualified in the modalities that they're doing and be proficient. And I think that then means it's open to everyone in order to go down that route. And especially when we're talking about people upskilling from what they're doing just now, if they're not holding regulated qualifications, there is pathways that are going to be in place. We're working on that just now. People are doing it just now already, actually, in order for them to gain the qualifications. So I'm probably talking more about the level 4, the skin needling, the skin peels, the laser, etc., which we do really, really hope that there will be a regulated training requirement that operators would hold when conducting these treatments.
Thank you. I was just going to add that I think the accessibility and availability of these treatments has absolutely exploded over the last decade or two, specifically. And as a result, the regulation or lack of, as it currently stands, just hasn't kept pace with the proliferation and availability of treatments, and it changes every year. Some of the procedures that we were talking about even a couple of years ago when the works first started here on types of treatments that should be considered within scope has moved on greatly, and I should imagine it will do again in the years to come. So for us, there is a responsibility there that, yes, there is issues around whether what's going on in the bill is proportionate and whether it will affect people in a more positive or negative way than others. But because of this accessibility and availability issue, we found that there's now a huge influx of people offering these treatments because they have seen a really easy and accessible way to make good money and careers out of offering these treatments. And a lot of people, I should say, and have said previously, are doing that with great levels of training and competence and are having very few things go wrong and such like. But there are also others that are taking part in essentially a race to the bottom, a race to cheap prices, and they're in competition with each other because there is just such greater accessibility to providers now than there was 5-10 years ago. And that ultimately risks vulnerable adults, especially young adults, who are very impressionable, who are essentially being sold services without the correct oversight and checks and balances on them to check that they should be having those treatments, that they understand the risks, that they understand the alternatives, and they look at whether they even need these things in the first place and the deeper reasons behind why they want them, the affordability of whether they can afford them in the first place. I mean, we also see situations of people taking out credit cards and loans and taking on debt in order to fund the proliferation of these kinds of treatments. So for me, that risk far outweighs the potential negative effects that could come as a result of restricting these the availability to offer these treatments to certain groups of people.
I obviously don't want to put words in anybody's mouth, but I think it sounds as though both witnesses are saying that the equalities impacts are leaning more toward the positive than the negative from the bill as it stands. The last panel did make, well, at least one witness made the suggestion that there are some additional issues, for example, in terms of seeing people who have perhaps language issues or accessibility issues in terms of the information provision that's available. One of the witnesses suggested that there could be improvements there that would mitigate any risk of disproportionate harm to people in that category. I'd like to ask for reactions on that, first of all, and then I'll come on to the issue of age as well.
I actually think at the moment the information, I mean, Leslie's organisation, Babtac, does a great campaign around trying to educate people to simplify the messaging around this. But I actually think the bill is beneficial to those types of groups of people that you were discussing, Patrick, because it's going to hugely simplify. This is what is safe. This is ultimately not a safe route for members of the public in a way that just does not exist currently. So we were discussing kind of this wild west, and it sounds dramatic, but ultimately it is essentially a bit of a Russian roulette when you go and have these treatments or go and inquire about the treatments as to whether or not you're going to get a safe procedure or not. And ultimately what this bill is setting out to do, and as I've mentioned, it does need some work, will go some way into improving that level of understanding from the public of, if you want to go and have any of these treatments, this is the avenue to do it that's a safe route.
Yep, I agree with what Victoria said there.
Thank you. And if I can finally come on to the issue of age, there does seem to be a broad agreement, a broad welcome for the limitation on an age limit of 18. I don't hear any dissent from that. But from one or two of the other comments that I've heard, that there's perhaps a question mark about whether any additional safeguards are needed for younger adults, people who are over 18, who are adults, but who may, for one reason or another, be particularly vulnerable to pressure, to kind of social media influence, to coercion, to some of the social pressures that exist that may drive people to access these services for perhaps the wrong reasons. Now, if we were talking about healthcare, I'm a very strong advocate of Gillick competency and those principles that young people, including those who are not adults, their competence to understand decisions about their own lives needs to be respected on an individual basis. But we're not talking about healthcare here. We're talking about buying services. And I'm personally kind of resistant to using the term treatment, which kind of implies that it's treatment for a condition. These are services on sale, on a commercial basis. Is there the need for any additional safeguard, do you think, in terms of younger adults or other groups who may be particularly vulnerable to those pressures and social influences?
I think we would need to lean to the operator practitioner to be able to be governing that. I think that there is a definite need for an age restriction for at least 18 for anyone going to get any of these treatments, unless obviously it is for medical, and there's many other reasons to have the kind of not aesthetic side of things. But I think that we have got to allow the practitioner to be able to assess that when they have the client or the patient, if is a medical provider, having them in front of them. I think they've got to be given that oversight, I think, to do that. I would say I think it'd be very difficult to manage. If not, I don't know how we could quantify it. I don't know how we would manage it. I think that that's probably something in the standard of training. I think that we maybe ensure that I think it's probably already there.
Yeah,
the body dysmorphia and everything, and I think just to make sure that that is part of the good practice. Sorry.
I was just going to sorry, I'm coughing for you. I was going to add to that and basically go over what Leslie mentioned earlier, which was around the difference between a regulated and accredited qualification and short courses. Technically, somebody that's had a regulated qualification, and you with your 30 years experience, they will know things that should be mandatory within any consultation period for someone wanting a service, as you mentioned. And that should be things like a cooling off period, going over risks and potential effects and things that may not go the way that you want them to go. And all of those different things should be discussed with the client, the patient, before they're going to have the treatment. And then there should be at least a 24-hour period, if not longer, whereby that person can go away. They're encouraged to look at and to speak to others, to talk it through, look up and do their own research before then going back and having the treatment. It shouldn't be that they come in and they have the ability to have that treatment straight away. That should just be par for the course for people that are operating reputably currently.
The higher level modalities, for sure.
Thank you both. Thank you, Convener.
Thank you. Elena Burton.
Thanks very much, Convener, and good afternoon. We only have a couple of minutes left, so I'm just going to quickly run through a few questions round about enforcement and compliance. And the first one that I have is, do you foresee any practical challenges that the aesthetic industry might face in meeting the bill's requirements on inspections and compliance?
At the moment, yes, because I think that, for example, environmental health they're very low in resource, but hopefully if we had a paid licensing scheme, we could raise the finance in order for us to fund it and to be self-funding. I think that's where industry bodies like ourselves and British Beauty Council would really be happy to work with, and we do work with environmental health just now, as it is with a lot of their governing body, in order to give advice and to help support them. And I think it's just ensuring that they are given the correct enforcement powers, and as I say, it needs to be quite strong to make people stick to it and to make sure that they know what they're looking for as well. I think that's very, very important, because that's what we hear all the time from environmental health. I don't know what I'm looking for. What is a qualification? What is a certificate? So we can definitely work with them for that.
I also think that Health Improvement Scotland have a responsibility to be part of that successful enforcement process as well, and the rollout of that. In the same way as in England, the Care Quality Commission have the responsibility for those more high-risk procedure, kind of the regulatory oversight of that. I think if we're saying that a Health Improvement Scotland premises is deemed to be a safe premises because of the practitioner qualification, because of the fact that they are inspected, etc., then they should bear some kind of responsibility for the oversight and supervision of that then feeds into this work.
Okay, that's very helpful. And in terms of the bill as it's drafted, do you support the offences and the penalties that are currently proposed in the bill? Or is there anything that you would seek to change within that?
I support what's in there currently, but I think it just goes back to what I said before about the licensing need for those other kinds of treatments as well, the lower risk but still require some level of licensing and oversight. And at the moment, the complete lack of provision within there for a license means that ultimately those people are able to continue offering treatments with little to no recourse for the consumer should something go wrong, or a degree of sorry, I've completely lost my word. We talked about this yesterday. That the client will know that that person has the correct level of qualification, that their premises have been inspected, and that they're ticking all of those boxes.
Yeah. Okay, and where we do see breaches under the legislation, do you feel as if there needs to be a level of improvement notices, education, working towards compliance? Obviously, if breaches are of such a standard that they are, you know, needing dealt with.
It's going to be proportionate. It's got to be proportionate. Can I just go back slightly, though, when you were talking about the licensing side of things? I think where that is so important, there's so many modalities that have got different levels of what they do. For example, skin needling, skin peeling and laser. For a beauty professional to do certain levels of skin needling, skin peeling and laser is absolutely fine. If you've reached a level 4 qualification, you are more than able to perform these treatments safely and to manage any after effects of that. It does need to be proportionate, though, because skin needling can go deeper, peels can go deeper. We can get that it's more, the laser can be ablative and taking away a lot more layers of the skin, etc. And this is where we need just a whole approach of the licensing leading into the HIS oversight, so that we can all work together. But as Victoria so rightly said, at the moment we are not going to be able to kind of hone in on the levels that we should be doing as non-medics and doing safely. At the moment, that's not got any oversight on it just now. So you can be doing the deeper peels, you can be doing the skin needling, you can be doing the laser. So that's where we need to be working on as well.
Okay, so should there be an even playing field in terms of, if we think about a tattoo artist and a tattoo studio having to be licensed versus somebody that's operating a laser to remove said tattoo?
Miss Whittam,
sorry.
there is actually a licensing scheme coming in parallel with this bill.
Okay.
Yeah.
That's very helpful. Thank you.
Thank you.
That answers my question.
Just in case we went off. Was there anything else you wanted to add? No.
We're out of time.
And so we have one final question from Sandesh Gohani.
Convener, for getting me in. In the previous panel, we were speaking about young people, and Louise said that her business would not do anything for anyone aged under 18. So did a few other panellists spoke about 18. What's the correct age for you and why, given people can vote in Scotland at 16, given the law talks about different sentencing for under 25? So what is the age that you think is appropriate?
I think you may feel differently here, but I think 18 is proportionate, because we're also looking at the way that our bodies are developing as we move into adulthood, and I think 16 is still too young to see how your body is developing and changing. Potentially you could say that it will continue to change into 21, etc., etc. But I think if we're wanting the parity with the UK, we were very instrumental in pushing through the legislation which restricted injectables for no one under the age of 18 back in 2021. So we would want parity with the UK in that respect.
Agree, 100% 18 for all the same reasons, and I think as well for enforcement, and I think for people sticking to it as well. I think that we'd get an awful lot more buy-in with that as well, rather than people can be married, they can buy a house, whatever, at that age and below. I think to then say that you can't go and get a treatment till you're 21 without parent consent, or you can't have it, I think would be overkill, to be honest.
Thank you.
Thank you. Can I thank the witnesses for their evidence this morning? At our next meeting on Tuesday, the 9th of December, the committee will continue its scrutiny of the non-surgical procedures and functions of Medical Reviewers Scotland Bill, taking oral evidence from 2 further panels of witnesses. And that concludes the public part of our meeting today.